Hello everyone, welcome back to the series of lectures in neurology. So in the last session we had discussed about the localization of stroke, especially the ICA, the MCA and the PCA tertiary infarcts. So now we will be discussing about brainstem syndromes. This is often considered to be a very difficult topic by undergraduate students, but this is a very conceptual and interesting topic. I have made a lot of visual mnemonics as well to help you understand what exactly is happening in these syndromes and to help you retain this volatile topic. Okay, so let's begin. So, we have to know a few very important concepts when it comes to brainstem syndrome. So, we will be learning each of these concept wise and then we'll put together all these concepts together and then we will understand each of the syndromes. So, the first concept, a very basic concept that you already know, is that any brainstem stroke will present with a characteristic feature which is called as your crossed hemiplegia. So what is the meaning of crossed hemiplegia? Crossed hemiplegia basically means that there is ipsilateral cranial nerve involvement and contralateral hemiplegia. Okay, so crossed hemiplegia basically means ipsilateral cranial nerve involvement with contralateral hemiplegia. So crossed hemiplegia is a very important characteristic feature of brainstem syndromes. Okay, then let us understand the concept number 2. The concept number 2 is to understand the organization within the brainstem. To understand the organization within the brainstem, the first is the organization of cranial nerves. We'll understand the organization of cranial nerves. So what are the structures which are present in the brainstem? So what are the structures which comprise of the brainstem? They include the midbrain, the pons and the medulla. Okay. So for the ease of understanding, we have represented the structures within the brainstem and the cranial nerves within the brainstem in the form of a triangle, and this is what we call as the brainstem triangle. Okay, this is the brainstem triangle, which is basically a topographic representation of the cranial nerves. Okay, it's not that anything in nature is called as brainstem triangle. No, this is a topographic representation. So we divide the brainstem into the midbrain, the pons and the medulla. How many cranial nerves do we have? So we have 12 pairs of cranial nerves. We have 12 pairs of cranial nerves. Now if you have to distribute these 12 pairs of cranial nerves between the three regions, between the three sections, your midbrain, pons and medulla, at each level, how many cranial nerves would you want to put? 12 by 3, which is equal to 4 cranial nerves. Okay. So, the cranial nerves 1, 2, 3, 4, you represent it at the level of the midbrain, 5, 6, 7, 8 at the level of the pons, 9, 10, 11, 12 at the level of the medulla. So, this is the first very important point. Okay. So, you have the midbrain, pons and medulla, 12 cranial nerves distributed equally, 4, 4, 4. So 1, 2, 3, 4, 5, 6, 7, 8 and 9, 10, 11 and 12 cranial nerves at the level of the medulla. So as we all know, nothing or no rule comes without an exception. So it's very important that we remember the exceptions to this rule. So cranial nerves 1 and 11, just cross it out because they do not relay onto the brainstem. So remove the cranial nerves 1 and 11. Okay, so that is your first exception. 1 and 11 do not relay onto the brainstem, just remove it. We had put it for representation purpose and for understanding and remembering purposes, they do not relay onto the brainstem. Okay, then cranial nerve 5. Cranial nerve 5 is what? It is your trigeminal nucleus. The trigeminal nucleus has 3 nuclei which extends throughout the brainstem from the midbrain, pons and medulla. What are the 3 nuclei? So we have the mesencephalic nucleus, and then we have the chief sensory nucleus, and you have the spinal nucleus of trigeminal nerve which is present in the medulla and it extends down into the spinal cord as well. So we have the mesencephalic, the chief sensory and the spinal nucleus of trigeminal nerve. So the trigeminal nerve is an exception because its nuclei extends throughout the brainstem and it's not only at the level of the pons. The mesencephalic nucleus is the one which is basically involved in your jaw jerk. It is involved in your jaw jerk. The chief sensory nucleus is involved with the processing of touch The spinal nucleus is involved with the processing of pain and temperature. Okay, and these sensory sensations are carried from where? The trigeminal nerve basically carries sensations from only the face. So it's not the corticospinal tract, it is the trigeminal nerve. Okay, so trigeminal nerve is involved in carrying the sensations from the face. Okay, fine. So that is about your fifth cranial. Then the eighth cranial nerve is also an exception because it has two nuclei, the cochlear nucleus and the vestibular nucleus. The cochlear nucleus and the vestibular nucleus. The cochlear nucleus is at the pons, the vestibular nucleus is in the medulla. Okay, so these are the three exceptions that you have to remember. Cranial nerve 1 and 11, you just remove it out of the picture. So 2, 3, 4. Okay, even 2 not to a certain extent, maybe the pupillary reflex of the second cranial nerve, which is your optic nerve, that goes to the pretectal nucleus in the midbrain. So the light reflex alone, that feature is part of the midbrain. Okay, then you have the major cranial nerves, which is your third and fourth cranial nerves, which are present at the level of the midbrain. Then you have 5, 6, 7, 8 at the level of the pons, 9, 10, 12 at the level of the medulla. And remember, fifth cranial nerve extends throughout. It has 3 nuclei. And the eighth cranial nerve again has 2 nuclei that you have to remember. Okay, so I hope this is clear. This is clear at which level, at which cranial nerve, which level it is present. So this is your concept number 2. Now, concept number 3. Okay, concept number 3, again a very important concept. Remember that when you have an embryological development, so developmentally itself, the motor structures are present more medially and the sensory structures are present more laterally. So this is a developmental feature. Motor structures are present more medially and your sensory structures are present more laterally, right? So the motor cranial nerves, the pure motor cranial nerves will be represented more medially in the brainstem, whereas the cranial nerves, which are mixed cranial nerves or pure sensory cranial nerves, are present or dispersed more laterally in the brainstem. Okay, so if you look at the triangle, the motor cranial nerves are medial. So at the level of midbrain, what are the 2 motor cranial nerves? It is your cranial nerves 3 and 4, right? So the third cranial nerve basically and the fourth cranial nerves are involved in what? They are involved in extraocular movements. The fourth cranial nerve supplies the superior oblique muscle. The third cranial nerve supplies almost all the extraocular muscles, including your recti and obliques. Okay, then which is the motor cranial nerves amongst 5, 6, 7, 8 at the level of the pons? It is your sixth cranial nerve. The sixth cranial nerve has only a motor supply to the lateral rectus muscle. The 3, 4, 6 are involved in extraocular movement. So the sixth cranial nerve, remember the mnemonic LR6SO4. So the sixth cranial nerve supplies the lateral rectus, the fourth cranial nerve supplies the superior oblique. They do not have any sensory functions, so they are present medial most. The third cranial nerve supplies all the other muscles of the eye except your 6 and 4. Okay, so the third, fourth, sixth cranial nerves which are involved in extraocular movement are present medially. Then at the level of the medulla, which is your motor cranial nerve, it is your 12th cranial nerve which goes and supplies the tongue. Okay, so which supplies the tongue muscles, that is your motor cranial nerve, which is present medial most. Now just adjacent to the motor cranial nerves, you will have branchial motor cranial nerves. Which basically supply most of the muscles of the larynx and pharynx, right? So branchial motor cranial nerves are present just adjacent. So branchial motor at the level of the pons is your fifth motor cranial portion, right? So the trigeminal nerve has both sensory and motor supply. Sensory supply we have just now learned. It basically takes the sensations from the face. What is the motor function of the trigeminal nerve? It supplies the muscles of mastication. So that is represented slightly laterally and including the seventh or the facial nerve, which is also slightly lateral representation. And the lateral most as you can see here is 5S. 5S means sensory nerve of your fifth cranial nerve. That is your sensory portion of the fifth cranial nerve which is present lateral most. Why? Because all the motor structures are usually represented medially and the sensory structures are represented more laterally. At the level of the pons, which are the branchial motor nerves which supply the muscles of the larynx and pharynx, 9th and 10th cranial nerves slightly laterally. And again 5S I told you is a exception, right? It extends up to the medulla and the spinal cord. So 5S is present here as well. And the 8th cranial nerve, the vestibular nucleus of the 8th cranial nerve is present laterally. Okay, clear? So this is how you complete your brainstem triangle, which is your topographic representation of the various cranial nerve nuclei. So I think this has made it very, very clear and simple. So remember just 2-3 rules. The first is that there are 12 pairs of cranial nerve divided equally amongst the midbrain, pons and medulla. Then remember the exceptions. So cut out 1 and 11. 5th cranial nerve extends throughout. What are the nuclei we have learned? Then 8th cranial nerve is also an exception to the rule. The 8th cranial nerve is also an exception to the rule. Then remember all the motor structures are medial, all the sensory structures are lateral, and accordingly you arrange the cranial nerves, you get your brainstem triangle and you understand the topographical representation within the brainstem. So the next time you get a cross-sectional image of the brainstem and multiple cranial nerves, there is no reason to get confused, right? So you can easily identify if a cross-section is given, is this a midbrain, pons or medulla? So at the midbrain, you get your 3rd and 4th cranial nerves. At the pons, you get your 6th cranial nerve. At the medulla, you get your 12th cranial nerve. So 3, 4, 6, 12, which is present medial most, or in multiples of 3, 3, 6, 12, multiples of 3. Okay. Then lateral most will be your sensory, and branchial motor is present in between. Okay. So this is very, very clear. So first rule we have understood about crossed hemiplegia. Secondly, we have learnt about the organization of the cranial nerves. Now let us understand the organization of the tracts in the brainstem. Okay, let us understand the organization of the tracts in the brainstem. So remember the tracts in the brainstem, the main tracts that we should know are the 4M and the 4S. So remember the tracts in the brainstem are the 4M and the 4S. Okay, so the 4Ms are those which are present medially and the 4S are those which are present laterally in the brainstem. Okay, so what are the 4M structures? They are medial lemniscus, medial longitudinal fasciculus, motor nucleus of 3, 6, 9 and 12 that we have already learned, and motor tracts. Okay, so this is again multiples of 3 if you have to remember 3, 6, 9 and 12. Okay, fine. So we have the medial lemniscus, medial longitudinal fasciculus, motor nucleus of 3, 6, 9 and 12, motor tracts which is nothing but your corticospinal tract. All of these structures are present medially. The structures which are present laterally are spinothalamic, spinocerebellar tract, spinal nucleus of trigeminal nerve and sympathetic fibers. Okay, so what does the medial lemniscus carry? The medial lemniscus we had learnt in our organization of tracts in the spinal cord as well, that we have the fasciculus gracilis and fasciculus cuneatus, which basically takes the sensations which is proprioception and vibration. So proprioception and vibration. So here in your spinal cord you have your proprioception and vibration which is carried, and it goes to your fasciculus gracilis and cuneatus which is present in your posterior column. Okay, it goes up, and then at the level of the medulla there is a nucleus gracilis and nucleus cuneatus. It crosses to the opposite side. Okay, so basically your medial lemniscus is this group of fibers from the medulla which relays onto the cortex, and it carries what? It carries the proprioception and vibration, or the posterior column sensations is your medial lemniscus. We will be learning about this in detail again in your chapter on spinal cord. So posterior column sensations are finally carried by the medial lemniscus. Then what is the function of the medial longitudinal fasciculus, or the MLF? The medial longitudinal fasciculus is basically your gaze or your horizontal gaze center. This is your horizontal gaze center. It is your horizontal gaze center. How is it acting? We will be seeing in the next slide. The motor nucleus of 3, 6, 9 and 12, they are your motor cranial nerve nuclei. Motor tracts is your corticospinal tract which carries information from the contralateral body. Then spinothalamic tract. Spinothalamic tract is what? It carries contralateral sensations, your pain, touch, temperature, right? Pain, touch, temperature is carried by spinothalamic tract, not proprioception and vibration, because proprioception and vibration is carried by medial lemniscus and posterior column. So pain, touch, temperature is spinothalamic tract. Spinocerebellar tract basically carries your balance related information from the opposite side. Then spinal nucleus of trigeminal nerve is your third S. Okay, so spinal nucleus of trigeminal nerve, we have just learnt here. What does it carry? It carries pain and temperature. Okay, it carries pain and temperature, and we have sympathetic fibers which we are damaged. If it is damaged, it results in Horner's syndrome. Fine. So what are we learning? Just to put things back into perspective, we are learning about the tracts in the brainstem. So we are learning about the 4M, 4S. 4M are present medially, 4S are present laterally. What are the M's? Medial lemniscus, medial longitudinal fasciculus, motor nucleus 3, 6, 9, 12, motor tracts. Spinothalamic, spinocerebellar, spinal nucleus of trigeminal nerve, sympathetic fibers are present laterally. It depends on which level. Is it the midbrain, pons or medulla, how it is arranged. Okay, clear. So till here we are clear. So till now what have we understood? We have understood the organizations of structures in the brainstem. We have understood the cranial nerves, we have understood the tracts. So this understanding is very, very important before we jump into brainstem syndromes, because unless we have this understanding, it becomes just a rote learning and becomes very difficult to understand the brainstem syndromes and why these things are happening. Okay, clear till here. Now let us move on and understand this concept of INO, which is internuclear ophthalmoplegia. Okay, so let us understand the concept of internuclear ophthalmoplegia. Let us understand the concept of internuclear ophthalmoplegia. Okay, so INO is basically a disorder which occurs when there is damage to the medial longitudinal fasciculus. The medial longitudinal fasciculus is basically the center for horizontal gaze. So it is the center for horizontal gaze. Okay, so let us understand the pathway for your MLF to understand what exactly happens in your internuclear ophthalmoplegia. Very, very conceptual topic. Okay, so the horizontal gaze. What do you mean by horizontal gaze? So when you are looking to the right side, what are the extraocular muscles which are going to get activated? This you would have learned in ophthalmology as well, right? So it is going to be your right lateral rectus and the left medial rectus. So looking to the right side, you have your right lateral rectus and the left medial rectus, which have to simultaneously contract so that you have a right gaze. So this is under the control of what? It is under the control of your MLF and PPRF, which we call as your supranuclear control for horizontal gaze. Similarly, if you have to look to your left, what is going to contract together? It is going to be your left lateral rectus and right medial rectus. And this is again under the control of your MLF and PPRF, right? So these are structures which are present at the brainstem. So why are we trying to understand this INO in more details? Because brainstem strokes can result in INO. So they can be damage to the supranuclear control of horizontal gaze. Okay, so let us understand the pathway. So first, at the level of the pons. At the level of the pons, we have a structure which is called as paramedian pontine reticular formation. Okay, this paramedian pontine reticular formation helps in your horizontal gaze. So, okay, so we are looking at the right side. PPRF. So the PPRF basically goes and supplies to the abducent nucleus and of the same side. Okay, so PPRF, right-sided PPRF is going to supply via the abducent nucleus, which is again present in the pons. Abducent nucleus is 6th cranial nerve nucleus. We had learnt the mnemonic 6th cranial nerve supplies which muscle? Lateral rectus. LR6 SO4. LR6 SO4. So the PPRF is going to supply your sixth cranial nerve nucleus or the abducent nucleus at the pons, and hence it is going to supply your right lateral rectus. Okay, it is going to supply your right lateral rectus. The PPRF also ensures that you have to have a contralateral contraction of the medial rectus also to move in the same direction, right? So, for synchronous movement of the right-sided lateral rectus, the left-sided medial rectus should also contract at the same time. Then only you will have a synchronous gaze, right? If you are attempting to move towards the right lateral rectus, left medial rectus should move together. So, the PPRF is going to control your contralateral medial rectus as well. So, your right PPRF is not only going to control your right lateral rectus, it is going to control your left medial rectus as well. Via what? Via the contralateral MLF. So, through the contralateral MLF, through the MLF of the left side, this MLF is going to go and it is going to relay its information into the left third cranial nerve nucleus. Via that, it is going to control the left medial rectus. Okay, fine. So, this is very, very clear. Let us understand the pathway clearly. So, the right PPRF is going to control the ipsilateral or the right-sided abducent nucleus. So, if you are planning to look to the right side, your right gaze, so right PPRF going to control the right abducent nucleus or right sixth cranial nerve for right LR contraction. At the same time, the left medial rectus has to contract simultaneously, and this is basically brought about through your MLF. So, through your MLF. Through your left MLF, it passes through the third cranial nerve nucleus and your left MR is going to contract. So, finally, what is the result? You're going to look towards your opposite side, right? So, it helps in moving towards your right side. So, this is very, very clear. Now, let us understand what is this internuclear ophthalmoplegia. So, let us understand what is this internuclear ophthalmoplegia. So, internuclear ophthalmoplegia happens whenever there is a damage to the MLF. So, there is a damage to the MLF. Okay. So, let us take this condition where you have the damage to your left MLF. Okay. Well, let us take the condition where there is damage to your left MLF. So, whenever there is a damage to the left MLF, on looking to the left side, what are the muscles that are going to contract when you look to the left side? You have your left lateral rectus and your right medial rectus. So, you have your left lateral rectus and right medial rectus. Now, the left lateral rectus is under the control of what? It is under the control of the ipsilateral PPRF, right? So, it is under the control of the ipsilateral PPRF. So, this is going to be left lateral rectus is going to be under the control of the left-sided PPRF. Is it damaged? No, it is not damaged. So, you can look to the left side. At the same time, your right medial rectus is going to get affected or no. So, the right medial rectus is under the control of ipsilateral MLF, correct? It is under the control of ipsilateral MLF, the MLF on the right side. So, is it going to get affected? No. So, the extraocular movements are full in a left-sided MLF lesion on looking to the left side. On looking to the right side, what are the muscles that are involved? You have on looking to the right side, what are the muscles that are going to get involved? So, you have the right lateral rectus and the left medial rectus. You have the right lateral rectus and the left medial rectus. Now, the left medial rectus is supplied by what? It is supplied by the left MLF. Now, that is damaged. Can you see here? So, your left medial rectus is paralyzed, and what happens if the one muscle is paralyzed? The other side, because it has almost the same supply, it is going to have an abduction nystagmus. So, you have an abduction nystagmus of the right eye on looking to the right. Okay, you have an abduction nystagmus because this is not at all moving, right? So, what will happen? The impulse which comes here will increase to move this, right? It will increase simultaneously so that it increases the movement of this, but it is completely paralyzed. So, the same impulse goes to the opposite side as well, and it increases the movement on the right side, and there will be an abduction nystagmus. Okay. So, complete paralysis of this eye on attempting to move to the right, it will not move, and you will have an abduction nystagmus of the right eye. And this is what we call as your internuclear ophthalmoplegia. Okay. So this is a quite difficult concept to understand. So I will just repeat it again for you. So when we look at the pathway, which is your supralateral control for gaze, what do we see? So we have a PPRF nucleus. So for the right side, the right PPRF is going to go and control the abducens nucleus, and it controls the ipsilateral lateral rectus. Okay, and the PPRF is also going to control the opposite side MLF, which goes and supplies the ipsilateral third cranial nerve. Okay, fine. Now we are looking at INO, where there is an MLF lesion. Fine. So whenever there is a left MLF lesion, on looking to the left, there is no problem. Why? Because you require your left lateral rectus, which is under the control of left PPRF, there is no problem. And on looking to the left, it is your right medial rectus, which is under the control of your ipsilateral MLF, which is your right MLF. So there is no problem there as well. But on looking to the right, because your left MLF is affected, your left medial rectus cannot move, and hence it will be paralyzed, and you have an abduction nystagmus of the opposite eye. Right? So this is your INO, slightly difficult concept. If you go back and read up the pathway again and again, you will understand this. Okay? Fine. So this is clear. Now let us move on to your midbrain syndrome. Okay? So the midbrain basically comprises of these portions, which include your tectum, your tegmentum, and your basis pontis. So it comprises of tectum, tegmentum, and your basis pontis. Okay, so the midbrain is usually visualized at two levels, at the level of superior colliculus and inferior colliculus. At the level of superior colliculus, which cranial nerve comes out? It is your third cranial nerve. At the level of inferior colliculus, the nerve which comes from the back side or your posterior aspect is your fourth cranial nerve. Now the brainstem syndromes can be classified as ventral brainstem syndromes and dorsal brainstem syndromes. Your ventral brainstem syndromes are Weber's, Claude, and Benedict. Your dorsal brainstem syndromes are your Parinod and North-Nagel syndromes. So we have ventral and dorsal. Ventral brainstem syndromes are Weber's, Claude, and Benedict. Dorsal are Parinod and North-Nagel. So we will be seeing each of these syndromes. So first we are discussing about ventral brainstem syndrome. Ventral brainstem syndromes. Okay, fine. So first syndrome is Weber's syndrome. So you can see that Weber's syndrome is highlighted in pink, right? So what are the structures that are involved? So here we have the corticospinal tract and the third cranial nerve. So in Weber's syndrome, because it's a brainstem syndrome, you will have corticospinal tract involvement, which is contralateral. You will have a crossed hemiplegia. So ipsilateral third cranial nerve palsy plus contralateral hemiplegia. What is the mnemonic? What is the mnemonic that you can use to remember this? So Weber equal to weakness. Okay, W for W. Weber equal to weakness. So ipsilateral third cranial nerve palsy with contralateral hemiplegia is your Weber's syndrome. Then let us see Claude syndrome. So what happened in Claude syndrome? In Claude syndrome, what happens is that there is extension a little bit into the red nucleus as well. So you have ipsilateral third cranial nerve palsy with contralateral ataxia. Okay, you have ipsilateral third cranial nerve palsy with contralateral ataxia. So how do you remember this? I have tried to make a visual mnemonic for this. So remember, Claude sounds like clown. Okay. So what does a clown do? A clown tries to move a lot of balls, right? So it tries to juggle a lot of balls. When he is juggling a lot of balls, he has ataxia on one side and the balls are falling down. Okay. So this is a visual mnemonic to remember your Claude syndrome. So Claude syndrome, to try and remember or imagine this clown who's trying to juggle balls, and because of his ataxia falling to one side, he's not able to juggle on one side. And this is your ipsilateral cranial nerve palsy with contralateral ataxia, Claude syndrome. You can also visualize the clown who is trying to see that the juggling balls are falling down. There is a down and out eye, third cranial nerve palsy. Fine? Okay, so that's what is depicted here. Then let us understand Benedict syndrome. Okay, Benedict syndrome is basically Claude plus Weber. It is Claude plus Weber, right? So can you see it is represented by this blue? So it involves a complete red nucleus as well. So what are the features? You have ipsilateral third cranial nerve palsy with contralateral ataxia, tremors and weakness. You have contralateral ataxia, tremors and weakness. Okay, so how will you remember this? So the visual mnemonic that I have given here is remember Pope Benedict. Okay, so to remember Benedict syndrome, you remember Pope Benedict. Okay, and he has a red hat. You always remember the popes have a mitre, right? A red color mitre. Now Pope Benedict is a very old person, so he has a lot of tremulousness in one hand and he uses a walking stick to walk. Walking stick, you can remember it as a mnemonic for weakness, and tremulousness is basically indicating your Benedict syndrome, and your red hat is going to remind you of your red nucleus involvement. So this is going to remind you of your red nucleus involvement. And who is he? It is Pope Benedict, to remind you of Benedict syndrome, Pope Benedict syndrome, and he is using a walking stick to walk with a lot of tremulousness to remind you that there is both weakness and tremors, okay, because of your red nucleus involvement. So ipsilateral third cranial nerve with contralateral ataxia, tremors and weakness, or Benedict syndrome is Claude along with Weber's. Okay, so I hope this is very clear. So what are we discussing? We are discussing about midbrain syndromes. The cranial nerve in the midbrain is your third cranial nerve. So all the midbrain syndromes, you will have third cranial nerve palsy. Weber syndrome, W for W, contralateral weakness. Claude syndrome, clown with ataxia. So they have ipsilateral cranial nerve, third cranial nerve, contralateral ataxia. Clown for Claude. Then Benedict syndrome, remember Pope Benedict with a red hat, red nucleus involvement, and he is having tremulousness, a difficulty in walking. He is using a walking stick because of weakness. So you have ipsilateral third cranial nerve palsy, contralateral ataxia, and weakness is your Benedict syndrome. Fine, clear. So this is about your ventral brainstem syndromes. This is about your ventral brainstem syndromes. So now that we have understood what are the ventral brainstem syndromes, let us understand what are the dorsal brainstem syndromes. So dorsal brainstem syndromes include two, which is your Perinaud and your North-Nagel syndrome. So Perinaud and your North-Nagel syndrome. So Perinaud syndrome, okay, the easiest way to remember Perinaud syndrome, remember all P's, P for Perinaud. Okay, so Perinaud syndrome is basically a dorsal brainstem syndrome. As you can see, that it is highlighted in green. So it mainly involves the posterior aspect of the brainstem. So the most common cause for a Perinaud syndrome is the presence of a P tumor, which is your pinealoma. So the most common cause is a P tumor, which is your pinealoma, and there is involvement of your posterior midbrain, which is your second P. Now in your posterior midbrain, a very important structure that is present is your pretectal nucleus. Now we know that in your light reflex pathway or your pupillary reflex pathway, which is your third and fourth P, the pretectal nucleus is where the light reflex goes and relays. So if the pretectal nucleus in your Perinaud syndrome, it is damaged, then there is loss of right reflex, there is loss of your pupillary reflex or your light reflex. What does the pupillary reflex or a light reflex do? Whenever you shine light, there should be constriction of the pupil, right? So this is lost. But the accommodation is reflex is present, and this is what we call as your light near dissociation. This is what we call as your light near dissociation. So in Perinaud syndrome, you will have light near dissociation because of pretectal nucleus involvement. So Perinaud syndrome, pinealoma, posterior midbrain, pretectal nucleus involvement. Okay, then you have two important signs. Okay, you have two important signs, which is your Collier's sign and your convergence retraction nystagmus. Collier's sign and your convergence retraction nystagmus. Okay, so let us understand that there are supranuclear control. There are supranuclear supranuclear controls to your extraocular muscles. Okay, there is a supranuclear control to your extraocular muscles which is present in this particular region in your posterior brainstem. So, there is a supranuclear control to your extraocular muscles which is present in this particular region in your brainstem. Now, because there is damage to it, the supranuclear control is lost. So, because the supranuclear control is lost, what happens is there is excessive stimulation of your cranial nerve 3 which results in excessive convergence, and there is simultaneous contraction of both the superior rectus and inferior rectus which results in a retraction of the globe. So, you have a convergence, retraction, nystagmus because of loss of your supranuclear control of your extraocular muscles, and this is a very characteristic feature of your penialoma or your Parinod syndrome. Okay, so it's very characteristic. What happens in this Collier's sign? So, in this Collier's sign, again because of loss of your supranuclear control of your extraocular movements, there can be damage to the levator palpebrae superioris. There can be damage to the levator palpebrae superioris, and a result of this, because of damage to the levator palpebrae superioris, what happens is there is lot of excessive eyelid retraction. This is what we call as the Collier's sign. So, excessive eyelid retraction and the uppermost part of the sclera becomes more prominent, and this is what we call as the Collier's sign. So, the other P that you have to remember is LPS damage. Then, another very important sign is your pseudo-abducens palsy. So, when there is continuous contraction of the superior inferior rectus, there is convergence, there is retraction, then you cannot move side to side, right? Because there is a loss of supranuclear control. So, this is your pseudo-abducens palsy. So, the LR is actually your lateral rectus which is responsible for your horizontal gaze, and supplied by the abducent nerve is actually not affected because the abducent nerve is present at the level of Pons. But because of this loss of supranuclear control, you can have pseudo-abducent palsy which is your next P. Okay. So, this is about your Parinod syndrome. So, penialoma, posterior midbrain, light near dissociation because of pretectal nucleus involvement, and they also have a vertical gaze palsy. They cannot move up and down. They can have a vertical gaze palsy. Then Collier's sign because of LPS. So, there is lot of eyelid retraction, convergence, retraction, nystagmus, and pseudo-abducens palsy. All of these features are features of Parinod syndrome. Okay, clear? So, this is about your dorsal midbrain syndrome, Parinod syndrome. Then, the next syndrome is your North-Nagel syndrome. So, how do you remember this confusing term North-Nagel syndrome? So, what is North-Nagel syndrome? North-Nagel syndrome is Parinod syndrome. Parinod syndrome. So, this is Parinod syndrome with contralateral ataxia. Okay. So, how will you remember this? Again, I am going to give you a visual mnemonic for this. So, when you think of Parinod, you remember the word Pari. What is Pari in Hindi? Pari in Hindi is angel. Pari in Hindi is angel. Okay. So, you visually remember an angel. Okay. An angel holding what? Holding the North Star. Okay. Holding the North Star. So, Parinod, Pari, angel holding a North Star, which sounds like North Angel or North-Nagel syndrome. So, North-Nagel syndrome basically is your Parinod syndrome with contralateral ataxia. So, your Pari is holding your North Star, but she is not able to hold it well, and there is lot of tremulousness, shaking, ataxia of that hand. So, that is your North-Nagel syndrome. This becomes very easy to remember. If you are asking an MCQ and they ask you what are the components of North-Nagel, very simple, try and visualize this. Okay. So, North-Nagel syndrome is Parinod plus contralateral ataxia. So, Parinod is Pari with a North Star with ataxia. Okay, this is the easiest way to visualize this. So, this is about your dorsal midbrain syndromes. Fine. Now, let us move on to your pontine syndromes. Let us move on to the pontine syndromes. So, what is the blood supply of the Pons? The blood supply of the Pons in your medial part is your paramedian branches of basilar artery, The lateral part is by your anterior inferior cerebellar artery. So medial part is by the paramedian branches of the basilar artery. Lateral part is by the anterior inferior cerebellar artery. Okay. Now the pons can be studied at the level of the inferior and mid pons and at the level of the superior pons, and they can be divided into ventral pontine, which is anterior, dorsal pontine, which is posterior, and lateral pontine syndromes. So we have ventral pontine, dorsal pontine, and lateral pontine syndromes. Okay. Now let us understand what are the highlighting structures which are present in the pons. So at the pons, what are the cranial nerves which are present? At the pons, what are the cranial nerves? They are your cranial nerves 6, 7 and 8. Okay. We have your fifth cranial nerve as well. So 5, 6, 7, 8. 1, 2, 3, 4 is midbrain. 5, 6, 7, 8 is your pons. So the motor cranial nerve is your sixth cranial nerve, which is present medially, right? So can you see in purple, this is your sixth cranial nerve. The seventh cranial nerve nucleus, how does it arrange? How does it arrive? So this, sorry, please cut the last slide. So the seventh cranial nerve nucleus, how is it arranged? So the seventh cranial nerve arises from its nucleus, which is in yellow, and moves around the abducent nerve nucleus and comes out. So it hooks around the abducent nerve nucleus and comes out. Okay, so that's about how your sixth and seventh are arranged, right? Fifth is what? Fifth is your trigeminal nerve, spinal nucleus of trigeminal nerve. So it is present laterally because it is a sensory one, right? At the level of the pons, you have your chief sensory. You have your chief sensory nucleus of trigeminal nerve, which is present laterally. Similarly, eighth cranial nerve nucleus is also present laterally because they are sensory in nature. Okay, and anteriorly you have the corticobulbar, corticospinal tracts. When we had learnt about the organization of tracts, they come anteriorly in the midbrain, pons, medulla, and then undergo diffusation. So they are also here. Okay, so just let us learn the names of the syndromes. Ventral syndromes are Raymond syndrome, Millard-Gubler, locked-in state, and Brissot-Sickard syndrome. The dorsal pontine syndromes is your foveal syndrome. Lateral pontine syndrome is your Mary-Fox syndrome. So very confusing names, but nothing to worry. I have given you visual mnemonics for these as well to remember the syndrome and what are the structures that can be involved. Fine. So let us start off with your ventral pontine syndromes. Let us start off with your ventral pontine syndromes, and these are present in your inferior or mid pons. Remember, inferior or mid pons. So in this slide, what I have done is I have highlighted which area of the pons is affected and which structures are affected and written the name of the syndrome in the same color so that you can identify it easily. So first syndrome is your Raymond syndrome. The first syndrome is your Raymond syndrome. So in your Raymond syndrome, this is highlighted in red. Can you see it is the ventral part of the pons? And what are the cranial nerves that is involved? It is a sixth cranial nerve. And what is the tract here? Corticospinal tract. So sixth cranial nerve with contralateral weakness. Since it is brainstem, you will have crossed hemiplegia. Ipsilateral sixth cranial nerve palsy with contralateral hemiplegia is your Raymond syndrome. So the visual mnemonic for this, again we have the recurring symbol for weakness in the opposite side. He is using a stick to walk. So there is weakness. And who is this man? The man is with 6 rays. His hair is like 6 rays. So 6 is to remember sixth cranial nerve. This is your 6 rays, and ray is to remember Raymond syndrome. Okay. So a man with 6 rays in his hair walking with a walking stick. So ipsilateral sixth cranial nerve palsy with contralateral hemiplegia, Raymond syndrome. Okay. So 6 rays, Raymond syndrome. Then next is your Millard-Gubler, which is highlighted in yellow. So here you can see that both the 6th and the 7th cranial nerve are involved, and you have corticospinal tract involvement as well. So Millard-Gubler, if you count the number of letters in Millard and Gubler, it is 6 letters, 7th letters. So this is an easier way to remember. So 6th and 7th cranial nerve palsy with contralateral hemiplegia. 6th and 7th cranial nerve palsy with contralateral hemiplegia is your Millard-Gubler syndrome. Then locked-in state is a very pathetic state to be in. It is right here in the ventral pons, right? So it involves bilateral 6th and 7th and bilateral corticospinal tract involvement. So there is bilateral 6th, bilateral corticospinal tract. Bilateral 6 means what? They cannot move to either side. Both the horizontal gaze is gone, right? Both the lateral rectus is gone. So they cannot move on either side. Bilateral corticospinal tract will result in what? It results in quadriparesis. So they are locked in. They cannot move their hands and legs, and they cannot move from side to side as well. They cannot see from side to side as well. That is your locked in state. Then remember Brisard-Sicard syndrome. Brisard-Sicard syndrome, which is highlighted in blue here. This is the other ventral pontine syndrome, which is your please cut the last line, which is your Brisard-Sicard syndrome. Okay. So this comprises of 7th cranial nerve palsy with contralateral hemiplegia. Ipsilateral 7th cranial nerve involvement with contralateral hemiplegia. Okay. So how is it different from your Millard-Gubler? How is it different from your Millard-Gubler? Because you do not have 6th cranial nerve involvement. You have only 7th cranial nerve involvement. Now what is the visual mnemonic that I have given here? So Brisard sounds like Briscard. Brisard sounds like Briscard, and Briscard is an English term which is used to describe soldiers. Okay. So why do you have to remember that? All you have to visualize is in Brisard-Sicard syndrome sounding like Briscard. Briscard was an English term used to describe soldiers. So you remember a soldier with this huge mustaches. What does it look like, these huge mustaches? What does it look like, this huge mustache? It is looking just like your 7th cranial nerve, which is hooking around or looping around your 6th cranial nerve nucleus in the brainstem, right? Can you visualize it? So this is going to remind you that this is a 7th cranial nerve palsy with a contralateral hemiplegia. And this is my representation of a soldier. It might seem funny, but yeah. Okay. So 7th cranial nerve involvement with contralateral hemiplegia is your Brisard-Sicard syndrome. Okay. Fine. So Brisard sounds like Briscard, which is a soldier with a big mustache. Okay. Fine. And a very characteristic feature is the presence of this facial cramps. The 7th cranial nerve involvement can cause irritation and can cause facial cramps as well. So this is about your ventral pontine syndromes. So just to revise, we have Raymond syndrome, which is 6th plus contralateral hemiplegia, Millard-Gubler 6 and 7 letters, so 6 plus 7 plus contralateral hemiplegia, locked in state, and Brisard-Sicard syndrome. How do you remember your Raymond? Remember the man with 6 rays, so 6th cranial nerve involvement, and he is walking with a walking stick, so contralateral hemiplegia. Right? So these mnemonics may seem a little funny or silly initially, but for those who want mnemonics and find it easier to remember with these visual mnemonics, please do use them. Right? So this is about the various ventral pontine syndromes. So once you go back and you revise this slide and try and understand which parts are highlighted, it becomes easier. Okay? So this is your ventral pontine syndromes. Now let us go on to your dorsal pontine syndrome, which is your Foville syndrome. So this Foville is in brown, so this is your highlighted area. So remember all F's in Foville syndrome. So Foville involves the face, F for F. So there is 7th cranial palsy with contralateral corticospinal tract. Now this will be similar to Brisard-Sicard syndrome, right? What is the difference? There is another F, there is PPRF involvement. There is another F, which is your PPRF involvement. So PPRF involvement can result in gaze palsy. Okay. So that is your Foville syndrome. So 7th cranial nerve with gaze palsy with contralateral corticospinal tract is your Foville syndrome. Clear? Fine. So now this is your Foville syndrome. Okay. Now let us move on to lateral pontine syndrome. Which is your Mary-Fox syndrome. Lateral pontine syndrome here we have represented in pink, which is your Mary-Fox syndrome. So in this Mary-Fox syndrome, there can be involvement of the spinothalamic tract. Remember, all the S's come laterally, right? All the sensory cranial nerves and all the 4 S's going to come laterally. So spinothalamic tract resulting in contralateral hemisensory loss. Then 7th cranial nerve involvement, right? Can you see here the 7th cranial nerve can be involved. So there is ipsilateral facial palsy. So vestibular nucleus involvement can cause vertigo. Okay. Then cerebellar tracts, which are your spinocerebellar tracts. Remember, involvement of the spinocerebellar tracts causes ipsilateral ataxia. It causes ipsilateral ataxia. Here you have ipsilateral ataxia and involvement of the corticospinal tract. Though it is present laterally, it can come downwards and involve the corticospinal tract as well. So there can be contralateral hemiplegia. Okay. So what are contralateral? There is contralateral hemisensory loss, contralateral hemiplegia. What is ipsilateral? Ataxia is ipsilateral because of involvement of the spinocerebellar tracts, and you can have 7th cranial nerve involvement of well. This is your Mary-Fox syndrome. So the visual mnemonic to remember your Mary-Fox syndrome is you remember a fox. Okay, you remember a fox. Now, what is our recurring visual mnemonic for weakness? It is walking with a walking stick. Okay, so he is on one hand he is walking with a walking stick and he is having sensory loss. So his hand is bandaged as well. So this is what I am showing here. So remember, in Mary-Fox syndrome, there is one side contralateral weakness, contralateral hemisensory loss. So bandaged hand, walking stick. And ipsilateral ataxia and tremors. So one hand there is tremulousness and ataxia and the fox is falling to the same side. On the other hand, he is using a walking stick to walk and it is bandaged, and this is your Mary-Fox syndrome. Okay, so contralateral corticospinal and spinothalamic tract is represented here, and this is your ipsilateral ataxia. Okay, so this is a visual mnemonic to remember your Mary-Fox syndrome. So that is about your lateral pontine syndrome. So we have learnt about ventral pontine and lateral pontine syndromes. So now let us move on to superior pontine syndromes. So in the superior aspect of the Pons, you can have a medial pontine syndrome, which is called as your Raymond-Sestan syndrome, and you have a lateral pontine syndrome. The artery which is involved is your superior cerebellar artery. The artery which is involved is your superior cerebellar artery. Okay. So in Raymond-Sestan syndrome, what are the structures you have to remember? Remember all the M structures. Okay. Remember all the M structures. So the MLF will be involved. You will have INO. So if the medial longitudinal fasciculus is involved, you will have INO. Can you see the portion which is highlighted in green here in your superior Pons? Then medial lemniscus involvement. There can be medial lemniscus involvement, which is exactly here. So it will result in contralateral pseudoathetosis, which is a movement problem which happens whenever there is disruption of, because of disruption of posterior column. Posterior column. I told you the posterior column basically carries sensation of proprioception and vibration, right? So if this proprioception and vibration is lost, when you keep your hand outstretched like this, there will be slow dance-like movements because your hand or the patient is unable to identify the proprioception changes where exactly, or the joint position of the hand, where exactly the hand is placed, and it results in this kind of a movement called pseudoathetosis, which happens due to your medial lemniscus involvement or your posterior column tract involvement. Then the motor tracts can be involved, which results in contralateral hemiplegia. Contralateral hemiplegia. Okay, and you can also have ipsilateral ataxia. So remember, in all the pontine syndromes, ipsilateral ataxia, and the other side, other features are contralateral. So you can have INO, pseudoathetosis, and you can have involvement of the corticospinal tract, right? So why do you have your ipsilateral ataxia? As you can see here, it is due to the spinocerebellar tract involvement. Spinocerebellar tract involvement. Okay, so this is your Raymond-Sestan syndrome. Then lateral involvement. So whenever there is a lateral involvement, what happens in your lateral pontine syndrome? There can be spinothalamic tract involvement resulting in contralateral hemisensory loss. Okay, then there can be involvement of the peduncles, which is your superior cerebellar peduncle. There can be involvement of the superior cerebellar peduncle and the spinocerebellar tracts. So this can also result in ataxia. This can also result in ataxia. Then vestibular nucleus involvement can result in vertigo, and the sympathetic chain can also be involved, resulting in Horner syndrome. Horner syndrome is characterized by ptosis, meiosis. So there will be ptosis of that eye, there can be meiosis. where the pupils are constricted, there can be anhidrosis or loss of sweating. So these are the features of a lateral pontine syndrome. So amongst the superior pontine syndromes, we have the medial and lateral. That's what we have discussed now. So medial is your Raymond-Sisson syndrome. So remember, the cranial nerves 6 and 7 are not involved here in your superior Pons syndromes. Fine. So clear. With this, we have completed pontine syndromes. Now let us understand medullary syndromes. Let us understand medullary syndromes. Now at the level of the medulla, which cranial nerve is going to get affected? It is your motor cranial nerve, which is your 12th cranial nerve. Apart from that, what other cranial nerves are there at that level? We have 9, 10, 11 and 12. So we have the 9, 10, 11 cranial nerves as well. So medullary involvement, especially if it involves your 9th and 10th cranial nerve, you're going to have a lot of dysphagia, dysphonia, dysarthria because of involvement of your 9th and 10th cranial nerves. Okay, so let us look at medial medullary syndrome. So whenever we speak about any medial stroke, the M structures, which are your 4 M structures, are going to get affected, and your motor nucleus of which cranial nerve is present medially? It is your 12th cranial nerve. So we will have ipsilateral tongue weakness. You will have ipsilateral tongue weakness. You will have wasting. You will have wasting because this is an LMN cranial nerve palsy. You will have ipsilateral tongue weakness. You will have wasting. You will have fasciculations of the tongue. Okay, so we'll have ipsilateral tongue weakness because of 12th cranial nerve involved. Right? And what are the contralateral elements that are involved? You can have corticospinal tract involvement resulting in contralateral weakness because the motor tracts, which is your next M structure, is your motor tract involvement, which is your corticospinal tract. So you will have contralateral weakness. The next M is your medial lemniscus, Because of your medial lemniscus involvement, you can have contralateral vibration and proprioception loss. Right? You can have pseudoorthosis also. This is exactly what is shown in the diagram. Right? So what is the arterial supply? It is the vertebral artery, which is usually affected in your medial medullary syndrome. Okay. So what are the structures? The pyramids are involved. So you have your motor tracts, contralateral weakness. Then what is the cranial nerve here? This is your 12th cranial nerve. So you have tongue weakness. Okay. Then you have this structure, which is your medial lemniscus. So these are the structures involved in your medial medullary syndrome. Remember all the M's. Then let us look at lateral medullary syndrome. The lateral medullary syndrome is also called as Wallenberg syndrome. Okay, lateral medullary syndrome is also called as Wallenberg syndrome. So what happens in this lateral medullary? A very, very important point is there is no weakness. So always remember that there is no weakness. Okay, and remember all the S structures which are present laterally. So first, spinothalamic tract involvement. Okay, spinothalamic tract involvement will result in contralateral hemisensory loss. So they will have contralateral hemisensory loss. Then sympathetic chain involvement. Sympathetic chain involvement will result in an ipsilateral Horner's syndrome. So you will have ptosis, meiosis and hydrosis of that particular eye. You will also have enophthalmos. The eye appears shrunken. Then what is the next S tract which is there? Which is your spinocerebellar tract. So spinocerebellar tract is going to carry the crossed fibers. It's already carrying the crossed fibers before. So spinocerebellar tracts is arising from the spine and goes to the cerebellum, and it results in ipsilateral ataxia. So damage to this results in ipsilateral ataxia. Vestibular nucleus involvement will result in vertigo. Then there can be involvement of the spinal nucleus of the trigeminal nerve. Spinal nucleus of trigeminal nerve is going to carry what? It is going to carry pain and temperature sensations from the ipsilateral phase. So there is ipsilateral loss of pain and temperature. From the face. So very, very characteristics. From the face there is an ipsilateral loss of pain and temperature. From the body it is a contralateral hemisensory loss. So here you can see that all the S structures are involved. The spinothalamic tract, the spinocerebellar fibers, the spinal nucleus of trigeminal nerve and the sympathetic chain. All the S structures are involved in your lateral medullary syndrome. When it comes to the cranial nerves, the branchial motor cranial nerves, the cranial nerves 9 and 10 will be involved. So you will have dysphagia. You will have dysphagia and dysphonia. Right? You will have dysphagia and dysphonia. Okay, you will have dysphagia and dysphonia. Then there can be involvement of the nucleus of tractus solitarius, which is also present in the lateral aspect of the medulla, resulting in loss of taste sensation. There can be loss of taste sensation. There can be severe autonomic dysfunction. There can be severe autonomic dysfunction in Wallenberg syndrome, resulting in resting tachycardia, and there can be a sudden precipitous drop in the blood pressure, and you can have a sudden cardiac arrest. There can be sudden respiratory depression, sudden drop in blood pressure, tachycardia, sudden cardiac arrest. Okay, then palatal myoclonus is also another very important feature. So when you open the oral cavity and see the palate, there can be a jerky movement of the palate, which is a palatal myoclonus, which can also be seen in your lateral medullary syndrome. So the characteristic features of lateral medullary syndrome: will you have tongue involvement? No, you will not have, because the 12th cranial nerve is spared. Then will you have weakness? Will you have weakness? No, because the corticospinal tracts are spared. It's always the S structures which are involved. And a characteristic feature that you have to remember is ipsilateral loss of pain and temperature in the face and contralateral hemisensory loss. So that is your Wallenberg syndrome. And if they ask you which artery, you will have to say posterior inferior cerebellar artery or your pike. Okay, so this is about your medial medullary and lateral medullary syndrome. So with this, we have come to the end of our discussion on brainstem syndromes. So I've tried to simplify it as much as possible. It is very confusing to remember the names initially and remember all the structures involved. Please do not attempt to memorize it. Please go through it conceptually. Try to understand the organization and try to recollect what areas will be involved, what symptoms you will have. It becomes very simple. So that's it about brainstem syndromes. Thank you.